are really, really fortunate to have a variety of solutions on stage today, all going after this important problem. Howard Rose, CEO of First Hand Technology, on my right. Beth Rogozinski, Chief Content Officer of Paratherapeutics. And Shai Gozani, President and CEO of Quell out of Neurometrics. I think I'll just start out by doing the obvious, which isn't so obvious if I can't make it work. Oops, let's go back a bit. Excuse me 1 second. Is that my first slide? I feel like I'm a little bit stuck.
That's from prescription?
Yeah, I can't seem to make this work, but let me try it from up here. So basically, this is a big problem. It's a bad problem. And as Jill already said, the CDC is actually a really great resource for keeping up on the numbers because they're changing so rapidly. And there's a really interesting parallel between the number of opioids that have been sold, prescription opioids that have been prescribed and sold, along with, which has quadrupled in the last 15 years, along with the number of opioid-related deaths that we've seen in a real parallel to that number. And the opioid deaths that we see are prescription as well as heroin-related. But I want to point out that the prescription-related ones are outstripping the heroin-related drug overdoses. So that's actually very stunning and something that we need to really open our eyes up about. I think there's a slide before this, so I'm going to try to skip back because I just want to get... Could you just go to my first slide for a second? I promise I go fast. There we go. And as Jill said, over 90 people a day in the US are dying from opioid overdoses. I think it's really important to know that when you hear about a drug-related death, 6 out of 10 times it's going to have involved opioids. And this is really a stunning factor to us, partly because a lot of them will have started from a prescribed opioid, so in a legitimate use case, a healthcare or pain setting. And the problem is we've not done a good job of sorting out, even predicting who's going to get addicted, who's not. But there's also a big relationship between people who are using opioids and a parallel or a companion drug or substance abuse. So it's very important we pay attention to it. So I'm going to skip to the last one now. And I do think there's a tremendous opportunity for digital tools to play a very important role for all stakeholders. I put up here just 2 things that the CDC is working on. And the point of it is education, information, but also at the very moment that you need it. So that support at the moment you need it. And that's where we have an opportunity to distribute the information and the support through digital technology. We have 3 very different technologies to present, coming at the problem from very different angles. So we'll start out with, I think, with First Hand and Howard Rose's solution.
Thank you very much. So my company is called First Hand Technology, and we have been working in the VR space for about 20 years. And pain relief has been a really big focus for us, and using VR as a way to address not just the physical pain, but also the mental health and also the other things that come along with it. So the really cool thing about VR is it's this high bandwidth channel into your brain and your body. And we can maximize that to really help the people who need it most. What my company does is we build virtual reality applications. We gather data in the background. We bring these to hospitals and clinics. We help them implement it. And we're also incorporating biosensors as a way to get a closed loop biofeedback system. We also white label applications and work with pharmaceutical companies, and maybe you've seen some interesting applications for empathy marketing or clinical and home patient care. There's a lot of good work that we can do with VR. I want to share some of the data that has come out of. We worked on an application called Snow World that has been really helped move this. I think move this field forward. This is a study that compares VR to no VR, and you see without VR, when we're subjected to pain and stress, you see really a lot of activity in the thalamus, the insula, and the ACC, and you can see from those images that with VR, there's a significant difference. And what's really cool is that the brain activity moves to other parts of your brain that are associated with much more positive things about resilience and coping, and we think there's a lot of potential there to induce plasticity and have a lasting effect. This is a study that compared 4 treatments, no treatment control, opioids, VR, and VR plus opioids. And if you look at a comparison, this is just the no treatment compared to opioids and VR. VR is doing better on pain unpleasantness, time thinking about pain, catastrophizing, and everyone's favorite, the amount of fun. VR is way more fun. And what's really interesting is the opioids are actually worse than the no treatment control. And I think that really speaks to this issue that underlies a lot of this, is that opioids don't actually cure us of anything. They just dull us out, and they remove our enjoyment and the quality of life. And so at least in this case, we can say that VR worked better than drugs. Other studies using Snow World and some other applications and things that we've built, you see it as an adjunct. So VR is used in a couple different contexts. One is to help people through procedures at the hospital. A lot of work with burn patients and high levels of pain, really significant reductions in pain for those the patients, and then also for chronic pain. And we're seeing 60 to 70% reductions for patients with chronic pain. And that lasts for hours and sometimes days later. Just a little bit about how this fits into the healthcare system and the payoff. Doctors, hospitals, nurses, and payers can all benefit from bringing VR. And I think that the work that we're doing is really this translation piece from all of this great research, and we've got the foundational science. But the real challenge is the social change, and really changing the way that our health system works. But the ground is very fertile for adopting new solutions. So we're very hopeful. And that's my story.
Thank you, Howard.
There you go. That's you.
That is me. Okay, well, my name is Shai Gazani. I'm the president and CEO of Neurometrics, which has developed the Quell product. We've actually been at this for 21 years, so be there by one. The company originally came out of MIT. We're actually a little bit of a new entrant, I guess, into the wearable and digital health space. We actually started, well, for the majority of our life as a company, we were a traditional medical device company developing neurodiagnostic devices, so devices to help physicians diagnose various kinds of peripheral nerve disorders, like carpal tunnel syndrome or diabetic nerve disease. And then about 5 years ago, decided to take our core technology, which is non-invasive neurostimulation, and apply it to a therapeutic platform, which ultimately became this product called Quell, which I'll tell you a little bit about. And more than that even, we actually switched our channel to focusing directly on the consumer, so delivering the technology primarily through consumer channels as opposed to traditional healthcare channels. So Quell is a wearable device, it's shown in the middle there, inserted in a band, to treat chronic pain. It's a high-powered neurostimulator. It's placed on your upper calf. It stimulates your sensory nerves with a high frequency for a high power neurostimulation signal. It feels kind of like a strong vibration or a pressure. In fact, my device is on right now. I only noticed it because I was thinking about it. And that essentially triggers your pain centers in your brainstem to overproduce your own endogenous opioids. So it actually thought to act through the opioid pathways, only using endogenous as opposed to external opioids. So it doesn't have the negative effects of external prescription opioids. In addition to being a therapeutic neurostimulator, it's also a digital health tool. It's integrated with an app that allows you to control the device, to see how you're doing in therapy. It's an hour on, hour off. It allows you to kind of watch where you are in your scheduled therapy. Also, the device has wearable technology in terms of an accelerometer, things like that, sensors to track your sleep, your activity, your gait. Various kinds of parameters are affected by chronic pain, and that data is then presented to you in the app. So it tries to provide you with objective information to help you optimize your chronic pain management. So it's designed primarily for chronic pain. It's a Class 2 medical device. All this data gets aggregated in the cloud, which is a really rapidly growing chronic pain database, probably one of the largest ones. And we're only starting to farm that data. So that's a device. As I said before, what we do that's somewhat not unique, and I wanted to show this slide for kind of two reasons. One is when you think of the consumerization of healthcare, people talk a lot about that, but what does it really mean? Well, one it means is that consumers are increasingly comfortable accessing significant healthcare interventions in a consumer setting, however you define that. So for us, where does somebody get this product? And these are people with pretty significant chronic pain. This is not, I played too much basketball on the weekend. This is serious conditions like significant low back pain, fibromyalgia, diabetic nerve pain, chemotherapy-induced peripheral neuropathies, things like that. They're picking up these devices in traditional consumer channels, as shown here, about a third online, a third in traditional retail, and a third through TV, such as QVC. It also tells you that the retailers are really interested in getting into this digital health wearable technology world and being part of the distribution channel. And so you see retailers here that you wouldn't necessarily think of as being interested in a medical, an FDA-regulated medical product, but probably one of our best channels is Best Buy. And that's not what I would have thought initially would be a channel to sell a product like this, but it's actually very, very successful, both in terms of the comfort of consumers in acquiring a technology like this in a setting like that, but also in the retailer's interest in merchandising and in educating consumers about it. So I think this is kind of interesting. I think it portends kind of how consumer healthcare technology is going to be provided to consumers.
Great, thank you. And Beth?
I have more to say than that. Are my slides not on there?
Can we move to Pear Therapeutics, please? Pear Therapeutics.
No, I don't see it on there. Well,
They have it. They
Yeah.
have it on the desktop.
no worries. I'll just introduce myself and start introducing the company while they're looking for this. I'm Beth Rogozinski. I'm the Chief Content Officer and one of the founding staff members of Pear Therapeutics. We're an e-health company that is looking to create actually software and pharmaceutical pairs. So we named the company Pear, P-E-A-R, not only because companies named after fruit tend to do really well, but because there's actually a methodology behind this. In our approach, we don't look to disintermediate the clinicians or the doctors or the pharmaceutical companies. We're really looking to integrate and treat the whole person. One of the things that we know and that we'll hear all week long at BIO and throughout the rest of the Digital Health Summit is that engagement and treating the whole person is something that's currently missing in our healthcare system. And so this is something that we're really looking to do. Unlike my colleagues who are on the stage that are looking to kind of stop this opiate epidemic, kind of before it starts, Pear actually has our lead product is a product called Reset and Reset O, which are about to be the first FDA-approved digital therapeutic software as a medical device. It's a Class 2 medical device, software only, for treating substance use disorder and opiate use disorder. So we think that this is actually a really important and pertinent way to approach this epidemic, because there are a lot of people that are already past the point of the interventions that my colleagues have in mind, and that they need the help that is now currently only available via inpatient treatment, 30-day treatments, and intensive cognitive behavioral therapy. So our digital interventions are, smartphone based and enable patients to get, access to the therapy 24/7. One of the things I like to talk about is there's 168 hours in the week. So crises don't occur when you're conveniently sitting in front of the clinician. So this is an always on, always available therapy that actually in our large scale trials, we've had one trial with over 500 patients in 3 public clinics. It has improved 3 times in general, across general populations, 3 times better than treatment as usual. In specific populations, when we look at subpopulations, in particular one subpopulation, these are patients that showed up on the first day of the clinical trial and tested positive for a urine tox screen, so these are kind of the most reticent patients. We had a 10x improvement over treatment as usual. So we're really excited to be able to be amongst the leaders in this field and trying to get scalable, affordable systems that are out there. We think that this will help to not only treat people in an affordable way, but reduce stigma and enable earlier access too. Our current approach to addiction treatment is we kind of wait for people to hit rock bottom before we treat them. And that's equivalent to waiting for everybody to be 500 pounds before we tell them that they need to lose weight, right? Our approach to addiction is a little bit broken. And, I think these digital solutions, because they can remove the stigma, they're a little bit more private, can also help us address these issues earlier.
All right, this is for Beth. For not having her slides, for powering through that. That was really great. I'm sorry about the slides. But I will say that what I'm excited about is to hear the problem being approached from different angles, but also with different technologies. So we have at the brain level, at the neuroplasticity level, whether you think of it as altering the perception of pain or whether you're really changing the pattern of the neuroplasticity itself. So at that level, we have the biochemical level, and we also have a behavioral sciences level. And on each platform, there's an opportunity to combine those and have the hybrid vigor of each of those strategies. So I'm interested in thinking about how do we get these technologies in more scaled and more into practice. I was a physical therapist, now I'm an orthopedist, so I'm in the pain business a bit, and I worry about how we can introduce these things earlier rather than introducing the problem without a paired solution or a companion to it. So I'd love to just hear from each of you. I know you've been at this for quite a while, but can you tell us what you think the hurdles are to scaling these interventions? Because the problem is growing much faster than the interventions are being adopted.
I think it's a huge issue and maybe kind of a threshold issue to make these technologies effective. We think about it from an awareness perspective. People, so we focus on chronic pain. I mean, that's our space. That's a huge number of people, about 100 million in the US. And really for us, it's finding ways to connect those people with information so they can evaluate our particular solution. So it's and I think in many respects it's classical marketing. How do you find out who's the candidate? How do you get to them? It turns out for a lot of our targets, they're in the older demographic, and online is not that effective. So we actually do heavy TV advertising because primarily on cable news, because we found that to be the channel to inform people or get them to a point that they're at least intrigued by the technology, and then they go online to learn about it. But I think it's really awareness building is the fundamental challenge.
For us, we actually, we're designed to be a prescription-based service. So for us, it's really, coming through a clinician and a caregiver on that side. And so our awareness campaigns are, unlike Shy's, where with a direct-to-consumer, it's really to clinicians and groups. So we've been working with some of the biggest behavioral health payers, the Gosnolds and Beacons of the world, and they're actually working with us to get the message out around our opiate product. Because we're being paired with buprenorphine, we're also looking to work with the pharmaceutical companies and have awareness go out that way. One of the things that we found is that clinicians are really receptive to this. I know in the last panel there was, some, back and forth with whether, the docs out there wanted this. What we found is that the docs absolutely want this. 80% of ER visits are mental health and addiction related. A huge number of people coming into GPs and internists have some mental health issues. And these folks are often put into a list and a long line of waiting for addiction docs or mental health providers. There's one large hospital group that recently got fined by the state of California because the average wait for a psychiatrist visit was about 2 years, right? So the docs that we're talking to are really very interested in these, and to give their patient something in a shorter period of time.
And then Howard, yours is in a completely different platform. So yours involves hardware, so it requires a purchase. Yours is sort of a BYOD solution, so a lower barrier to entry just in terms of what technology you need. Yours is a little bit on the other side of the spectrum of needing a technology that most people don't have in their home. So how is that an impediment, or how are you facilitating getting that into the hands of people who need it?
Well, scalability is something that I think a lot about, and it starts with, there's different ends of it. One is the payer side and how you're going to finance it, and there's an education side about how do people find out about this and how do they feel comfortable with it. On the equipment side, which is, there's no installed base for VR right now in hospitals, and I would just make the distinction that we're really focused on the patient. We're really focused on putting this in the hands of patients rather than, other uses of VR for training doctors and things like that. And we have developed a very scalable solution. We've partnered with a number of very large technology companies that are, becoming our OEM partners, and we're able to. We just delivered systems to a large hospital chain that is able to. We have a scalable model. And a scalable model is not just having the equipment, but actually making it fit into the environment of a patient room or a clinical examination room or an outpatient clinic or whatever it is. And so there's a lot of, pain happens in so many different places in our health system, and most of it happens at home, right? So our first focus is really to get this into the clinical environment. That's a place where we can get a lot of use out of a few number of machines and really prove that this, what we found through the science is really proving itself out, both in terms of wider scale, larger studies, but also that the economic model is going to build over time. What we're seeing is that those the numbers look really good in terms of what they're able to get in terms of better outcomes and reducing pain and changing practice. But changing practice is a long-term kind of proposition.
I think that's a really good point, because we talk about innovating in personnel, process, and technology, and for each of these, the workflow needs to change, and the awareness has to be there. But also what you've done nicely, which I ask you to pay attention to, and you've done it, is I really think we need to show that these things work. So the effectiveness in care and outcomes, but now let's switch to the effectiveness in cost, because as I've said to each of you, we can't keep adding cost to the healthcare system. So could you speak a little bit about how you plan to demonstrate the ROI and over what period of time, and some of the mundane things, but they're also the things that make things like this take off and be sustainable rather than just be a pilot or a research project. So can we talk a little bit about effectiveness and cost and how you have seen it or how you have modeled it to make a difference?
Sure. So I think in terms of effectiveness, we look at it both in the traditional clinical setting or clinical fashion, and we do clinical studies. We've had some good results to date. We actually have a very interesting study that's just wrapping up here at Scripps, specifically looking at opioid use reduction in cancer patients. So we'll be presenting that data later this year. So we do those kinds of studies. But in a consumer product, ultimately the consumer makes a very individualized decision. And the way we've approached that is what we call kind of an N-of-1 study. And what we do is we give the consumer 60 days to try the technology. At 60 days, which is about what a typical pain study is, duration of a pain study, they can choose to return the product for full refund. So they're doing their own essential individualized study, and if it works, they keep it. If it doesn't work, they return it. And so those are the two types of studies that we how we approach this. And what's really interesting is that the efficacy that we see in the traditional clinical studies, which is about 70 to 75%, has been mimicked in the return rates. So we're actually seeing that same level of sort of efficacy in these N-of-1 studies. In terms of cost effectiveness, I think it's a very individual decision. This particular product is $250, which to some people that's the best investment they could possibly make. To others, it's a lot of money. And again, so each consumer makes their own decision based on their own personal results. But we don't think about it in the broader cost effectiveness way, at least at this point.
I hope you will, excuse me, because you're gathering data.
Yeah.
Our whole, I'm good, thanks. Our whole clinical approach has been around the health economic outcome research model, and even in all of our clinical trials, we've looked at partial replacement of clinical time, and in mental health, mental and behavioral health, the majority of the costs are the one-to-one intensive time of cognitive behavioral therapy. In addiction, we use a flavor of CBT called community reinforcement approach. And that, one of the things in the digital setting that, we can not only deliver it more cost effectively, we can deliver it more consistently, more frequently. As I mentioned earlier, it removes friction points. The patient doesn't need to drive across town to get there, get a babysitter, leave work, all of those other things. So our entire model is based on a cost savings model. And we compare it directly to, treatment as usual and standards of care for, both gold standards of care and then, lower levels of care and the like. And where the economic value really starts to blossom and bloom is when you start to look at preventive comorbidities. And especially in addiction, we see everything from abscesses and cellulitis to congestive heart failure, HIV, and Hep C. But all of our models are really based on this one-to-one comparison with treatment as usual.
For us, we're really interested in kind of shifting the model of how care happens, and so that our model is to try to transition people from being health consumers to health producers, and instead of just focusing on consumption, to look at all of this untapped capacity that is in all of us to perform and to be better and healthier on our own. And just to give you a small example, we have a study going or a pilot going at a cancer center. The doctor told me the other day that he has a patient he's been following, and they're taking drugs, and they're not getting any change, and the only change in their pain was the day that they used VR, and so part of this is that we have to get it into the flow of care so that people can have that observation, and people need to be using alternatives on a regular basis. And the cool thing about VR is that it gathers all this data. We get all that data in the background so we can understand how behavior and environment and how these interventions can sort of feed on themselves. So as we use them, we get better results, we get better data, we can build AI engines to support these things and to make them adaptive. So there's a tremendous future in terms of this, and I think VR is one solution that can integrate with a lot of what you're doing at Pear, can integrate with other devices. It's not an island in itself. It's really looking at an environmental intervention. And if you look at the research, environmental interventions are one of the most effective ways to change behavior and to change attitude, and people will rise to the occasion.
I want to draft on something that Howard said, because when at Pear we look at 4 levels of efficacy. Right, first we need the randomized controlled trials. We need the clinical trial data, and that data has to come back and it's got to show efficacy. But it's also got to work for the clinicians, and it's got to work within that flow of healthcare. If it doesn't work there, you're stopped, you're stymied. The third thing is it's got to work for the payers. And then finally, it's got to work for the patients, right? The patients have to want to engage in this. And so unlike other businesses where you just look at, how can we help one audience? There are a lot of stakeholders involved, and we look at efficacy across the 4 pillars of all of this.
That was a really nice summary of that. I want to say we're almost out of time, but
One of the things that I will say is thank you for stepping up to this problem. It is massive. It is, and it's so hard to solve. And as a provider, I feel like I'm a part of the problem, and I want to add more to the solution side. So I'll be looking at each of these. The question I have, though, is you're in stiff competition with a whole phenomenon of others doing other types of behaviors, and they try to draw people in. And addiction is just a very hard field. How will your technologies, or what are you seeing in terms of not having an extinguishing effect, which we know sometimes happens, or an adaptation that happens neurologically, not having just a dropout effect? You know, we have trouble with wearables and apps in long-term adoption and sustainability. And then also the same thing, because in some venues, VR needs to get new content all the time to keep people engaged. So just as a final note, how are you ensuring about the ability for these to have ongoing effects and compete against this battle we're in?
Yeah, I think tolerance and desensitization is true in any, in any analgesic methodology. And I don't have the answer to that question. I think it's fundamental as one to recognize it, and then to try to work towards mitigating it as much as possible, but always understanding it's going to be there.
Yeah.
These are short answers, I'm sorry.
Yeah, no worries.
We got a signal.
And for us, we look at, how we can continually improve the app and the engagement. And so, we have a number of people on our teams that come from traditional entertainment, media, gaming, and the like. And so, we're looking at multiple different reward systems, social contingency management systems, and other ways that we'll be able to engage people.
So I have to make this comment, because I think you're all sitting on more than you think you are. You're sitting on an answer to opioid addiction, but you're sitting on a platform that's good for so many things.
Yes.
I keep thinking if I had VR when I was having babies, I wouldn't have even thought about having the baby. I would have just been in La La Land. Right? And so if you look at Quell for other training, and if you look at what you're doing for other things, and I look at Salesforce, and that's the thing that Salesforce is Salesforce, but they will skin it different ways for different problems, and I think that's part of what the medical folks have to do.
Yeah, and just to that, so Pear Therapeutics has a full pipeline of drug software products. Beyond our addiction products, we have products already for big, serious mental health issues, schizophrenia, post-traumatic stress disorder, traumatic brain injury. We've been working with the VA and running trials on a number of these different products. So I agree with you completely. And I think that what we're really going to see is that we have to, going back to the initial talk that was here today, there's got to be more personalization. No one size fits all for pain relief or depression management. And so we will need more content. Howard's company and my company will need to kind of, create more content to service all of these people, but the platforms underneath it can remain the same.
And Robin really summed up the session for me nicely, because what I was getting at, by taking on such a difficult problem, you can port this to all the other aspects in healthcare that require choice and lifestyle and behavioral sciences because of the work that you're doing in this space. So thank you very much for your efforts, and we look forward to them.
Thank you.